Hello and welcome to the JCN Clinic Podcast show. I'm Jessica.
And I'm Christine.
And today, Christine and I are talking all about chronic reflux. This was actually a requested topic on our socials. I put up a story and someone asked about this, and I was saying to Christine, I was like, yep, sure. We've got a podcast on that too. It'll be a great listen. And I scrolled on through all the podcasts and lo and behold, there was not one. So I think we've mentioned it multiple times in different formats. I think actually, Christine, particularly, you know how we did the one on the stress, like we talked all about the stress connection. Yes. I mean, obviously it's come up in multiple scenarios, but we haven't actually talked about it on its own. Maybe, and whether it was you and I, maybe on a live or something as well. I don't know.
Yeah, I know. It does feel really familiar, so I'm kind of surprised. But yeah, it must have been in amongst another one, I think.
Or there is a chance that my scrolling through missed it. I'm just thinking this now. And actually there was one and I just missed it. And you know what? That's worst case scenario. And it's always good to refresh things with a new lens, because it was probably me and Carissa, and I've got Christine today. So here we go. So yeah, chronic reflux, or just, I guess, reflux in general. But I guess the chronic component I wanted to bring in because of the chronic nature of digestive issues that we see at the clinic, and just how something like reflux can progress. So I think first and foremost, as far as like what is reflux, I mean, most people listening, I would imagine, know what just general reflux is, as far as the experience of the repeating of, it feels like food, but sometimes it's not food, but just coming up from the stomach. So it feels like that chest area where the stomach is, and it can feel like the food is coming back up. Or it can actually be just a sensation of like it can be quite gross actually, like a warmth or a liquidiness coming back up from the stomach, that can definitely have stomach acid in it, which can be very uncomfortable and quite painful. So reflux, that's sort of the way I would describe generally the sensation of reflux. But we have different progressions of reflux, which we're going to dive into, and different terminology. Before we do that, though, Christine, what do you think about how often we see this in clinic? I'm really curious about what you think with your clients.
Yeah, I actually see it really quite often, to be honest. And I think there's a lot of the clients that I see, you know, there's a lot going on. And so, you know, they don't necessarily come in purely for reflux. It's generally just, you know, I want general gut support. And it's, you know, when we're doing a case taking, it's one of the things that does come up. And so, yeah, I do actually see it quite often, especially if there is more of that chronic nature from that sort of gut perspective as well. So it's something that's been underlying, which we'll obviously get into, but it's been this overall picture that started to build and build and build, and then potentially reflux is one of those later symptoms or complications that they might have been experiencing.
Yeah, no, I'd so agree. I've definitely had some clients where it has been their primary concern, but usually they'll fall into some of the categories of what we're talking about as far as more of a kind of chronic ongoing condition. But it's surprising how many people are experiencing it who come for other sort of primary gut symptoms, but when you go through their case, like, it's often there. And I don't know, like, it's one of those things too that as a symptom, I feel like there's an element of people thinking it's normal. I don't know, like, do you reckon? Yeah.
I was actually going to say that I think that a lot of people, when we are doing that deep dive, they don't necessarily, like, I'll question them and they'll be like, oh, well, actually, now that you say it, I do get da 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 da. And so it's, that one, they haven't really connected the dots, but two, I think that it is especially probably more in like the older demographic as well, whereas it can be seen as just a part of aging. and that's
Mm-hmm.
just normal. So yeah, I think it's often overlooked because of that. But the other thing I find interesting is that I think a lot of people don't necessarily know what reflux is. Like they might, you know, as might know what heartburn is, so they get that, that
True.
burning in the chest.
Mm.
But when they think about reflux, a lot of the time I'll have to prompt clients as well, and it's like, well, actually, do you experience X, Y, Z? Is it like this? And so there's kind of so many different ways it can actually present from the symptom picture as well. So I
Mm-hmm.
find that can, complicate things a little bit for them.
That's actually a really good point, pointing out, the heartburn sensation versus like the reflux nature. And sometimes, or a lot of the time, they can come together, but some people will just be like, oh no, it is the heartburn, that like pain, but there's nothing kind of coming up. Although there can be, I guess this is part of where we're going, like there can be silent reflux where they don't actually feel it. I was also just thinking in regard to like considerations of normal. I remember as a kid, my dad used to just constantly have quickies around, like in the car, or it was like, oh yeah, it's just quickies. And anytime he would have, there was multiple different things, but I remember meat pies. Like I remember being in the car and like, we'd stop at a bakery and he'd eat a meat pie, and it was always like, yeah, got to have a quickies. Like it was just associated. You eat the meat pie and you have the quickies. And I was like, oh yeah, that's normal.
Yeah.
Now I'm like, wow, that's really not
Yeah.
ideal.
Well, it's funny you say that because and I can't remember what brand it is, and I wouldn't mention it anyway, but there is an ad that I see often on, on TV or whatever, and it is for some sort of, it might be quickies or it's some sort of Gaviscon or something like that for reflux. And the way that they target the ad is very much for, if you're going out for like a spicy meal or you're having, this sort of food, don't worry, enjoy yourself. This is what we're here for. And it's like, well, actually, I feel like that sort of narrative then just exacerbates that idea that it is normal and so anyway.
So true. So I guess yes, different types of presentations. So I'll give a little bit of an overview and then curious to hear your thoughts too. So when I guess just speaking to reflux in general terms, like we have someone that's experiencing those symptoms of reflux, but what can happen is that it can progress to where, and usually someone will come to us and they've had these types of diagnosis where it's been going on for so long and it's become so painful and disruptive that you've taken yourself off to see a doctor, and then you've potentially been referred to a gastroenterologist and they've gone down the diagnosis path. This can also involve people who've had endoscopies and just where they've physically gotten in there and had a look, or gastroscopy. Is that the right term as well? Yeah.
I think they're interchangeable.
Yeah. There's a diagnosis where they've gone in and physically had a look. So essentially, I think about this as more of like silent reflux could be one of them, where someone's experiencing like the heartburn and maybe some other digestive issues, and then they go and have the scope and they're being told with the findings that they have silent reflux. I've definitely had clients have that happen. And they're like, oh, wow, I don't have any symptoms, but they're telling me that I've got all this inflammation and damage going on in my esophagus. Then there's clients that get diagnosed with GORD or GERD. It's kind of like an interchangeable term. Essentially with this, again, I think of it as a more of it's like taking something like reflux that is chronic and essentially giving it a name. Like it's all of the same symptoms, but it's just saying you have chronic reflux and we call this GORD, which I've got written down in front of me so I didn't forget the name of it off the top of my head. Gastroesophageal reflux disease or gastroesophageal reflux disease. Both the same for GORD and GERD. It's just where they place emphasis on the O or the E. So that one for me, when someone tells me or puts on their treatment or their intake form that they're coming for this primarily or they've been diagnosed in the past, I personally think about it in a similar fashion to like a chronic reflux. Whereas eosinophilic esophagitis, that is definitely something that I'll see with clients where we've got like a really sort of stronger level of inflammation and the immune system being involved with these eosinophils, like, and essentially when you see something like this, there can be a deeper level of damage to the esophagus. And also the concern with something like this is how it can potentially, worst case scenario, progress to the cells potentially, I'm being careful with my language, not freak people out, but potentially the cells becoming cancerous and mutating through like such chronic inflammation and damage, which is very, very rare. But it is a reason I think that when clients get diagnosed with this, like they'll always flag it with you, and it's always a really big concern because their doctors have pointed this out. It generally, again, is very, very similar on what they're experiencing symptom wise, but I always think about it as like a more of like a disease like process of like how the immune system is involved. Thoughts?
Yeah,
Anything you
well,
wanted to add or anything I've missed with my info
no, I
dump?
think that I think it's quite interesting when it comes to GORD because, or GERD, whatever you want to call it. But the reason I find it quite interesting is that often people will be quote unquote diagnosed with it based on a symptom picture, which technically, you know, as far as my understanding goes, is almost throwing it into the same category as a syndrome. So that when we're looking at something like IBS, PCOS, it's not necessarily that there's this pathological process. And when I say that, I mean it's not as if they've gone in and they can see that, you know, the cells are, you know, changing and there is that inflammation there. It may be that they've gone, okay, do you get heartburn? Do you get reflux, regurgitation, and they do go through and do a bit of a symptom check for you. And then that you may get that sort of diagnosis of GORD, which technically is somewhat incorrect. When it is labeled a disease, it's generally because there is that pathological nature. So they've actually found something on a cellular level, on a functional level that isn't normal. They're basically diverting from a normal process. So I think that if you've gone down that route and haven't had any sort of investigation in terms of a gastroscopy or an endoscopy, then I'd have a few more questions. Whereas if you are somebody that's had all of these symptoms and they've gone down the pathway of actually looking through those lenses, through those, you know, forms of investigation, and then you have seen that cellular change or there's, you know, visible inflammation within that tissue, to me, that's almost two different things that we're dealing with. And if it's, you know, led to something like Barrett's esophagus, which is, you know, a whole other thing as well, then I guess the treatment, from at least from my perspective, the way we would approach that is going to be a lot different to somebody that is essentially presenting with symptoms only and hasn't had those types of procedures done yet.
Yeah, really good point. Yeah, it's interesting, isn't it, with something like GORD and the use of the word disease, like it really is more so a classic syndrome, like as far as I like your analogy of comparison to IBS. It's just essentially a term that's used to describe a collection of symptoms.
Yeah.
But I think, yeah, probably the naming of it also, I would be interested in people's listening's thoughts on this. I think the name of it can maybe lead clients to feel, or just people in general to feel like it's a little bit more serious. Just, yeah, I'd like a client that talks about, oh yeah, I have reflux, versus like, no, I've been diagnosed with GORD and like I've got these medications that I have to take and it's quite serious. And like, I'm not saying it's not a serious, like, of course it's very disruptive to your life, but I just, to be honest, hadn't really thought about it in that way, that the way that disease is whacked onto the end of that versus realistically, okay, come on guys, this is really more of a syndrome.
Yeah, absolutely. And I think that, again, it depends on where the client's at and where they've been in terms of, have they gone down that route of diagnosis or I should say more investigation, because
Yeah.
sometimes you may still be prescribed medication. So that might come in the form to like of a H2 blocker or a PPI, a proton pump inhibitor, that sort of thing.
Yeah.
You may be prescribed that before going down the route of, you know, those further investigations and having a look at the scopes and things like that. So there's a little bit of nuance, I suppose, in that. In it really depends on where the client's at in terms of what have they actually had tested, what do they believe to be going on. And yeah, so I just wanted to add that in there, because even if you've been prescribed medication, it still may not necessarily be like a pathological disease.
Yeah. Yeah, absolutely. So you just referred to a few medications that are used. Do you want to speak first to those common medical treatment processes once someone is potentially diagnosed in this realm, or whether they are just going in and seeing their doctor and have been told that they're experiencing quite disruptive reflux? Like, what are some of the common treatment methods that we see?
So the two that I see most often, so you've got the ones that are, I mean, they're not a prescription medication, but they're still quite, I suppose, intensive in how they operate. And that is what you would buy like at the chemist. So that's generally something like the Quick Ease or the Gaviscon, for example. And the Gaviscon, I believe, does actually have two different formulations. There's one that has, don't quote me on this, but there's one that has, I think it's the calcium alginate in it. I haven't looked that up in a long time, but I'm pretty sure that's the one in it that kind of has a bit of a two-pronged approach. So it actually forms a bit of a raft over an acidic stomach contents, and that's how it can basically prevent any sort of backflow up through the esophagus. They're probably the two, that Quick Ease and Gaviscon, again, they're brand names, but they're the two that I would see a lot of people take when they haven't necessarily gone down sort of a pharmaceutical approach yet. And they can be very effective for symptom management. I've actually seen that they can be quite problematic as well in terms of coming off those medications can present challenges as well. But then you've also got more of that sort of prescription medication as well, which, to be honest, for me personally in clinic, the one I see the most often would be a proton pump inhibitor. It's pretty rare that I will see someone on a H2 blocker.
Yeah, same.
But yeah, proton pump inhibitor. So essentially what that's doing is it's working at a level of inhibiting, this is very simplistic, but inhibiting the excess production of stomach acid. And so the thought process behind that is that you've got too much stomach acid, that's backflowing up through the esophagus, and that's what's causing damage and what's causing a lot of your symptoms. I don't know how far we'll go into it today, but that's not necessarily what is always driving symptoms of reflux and heartburn. So that's why a lot of the time we'll see clients that may have been prescribed a PPI but haven't seen any improvement in symptoms, because what we're working with is not necessarily an excess of stomach acid. We're working with a number of other reasons. Having said all of that, I can see that there is a time and place for PPIs, even in certain clients that don't necessarily have a stomach acid issue, don't necessarily have an excess of stomach acid. So sometimes I've seen gastroenterologists that will still prescribe that simply to protect that esophageal lining if there is more of a significant disease pattern going on. Just as an interim phase, just to not exacerbate, while that might not be the root cause, and while they may be very well aware that this is a symptom approach, a band-aid approach, I can understand why that can be called for in certain cases as well.
Yeah, well explained. Yeah, and as you say, I think we will sort of unpack this, because I think it starts naturally to flow into the underlying causes more and like the way we would approach this. But I've definitely see clients that are on PPIs that definitely aren't feeling any improvements, but I do see clients that feel better on them, but I would 100% still be questioning whether that is just masking. Like, obviously it's masking as in their symptoms feel a little better, but it's not dealing, of course, with the underlying problem. And I think the issue around, as you said, the PPIs is still this framework of like, oh, you're overproducing stomach acid, like that is why. And I truly think and have seen this clinically over years that like the amount of people that are just overproducing stomach acid and that is the main cause is so damn rare. Like, it's just, I just think it's more that of course the medication provides relief, so then it reinforces that kind of belief system, more so again within the person using it. So there's like a thought pattern of like, I have too much acid, I produce too much acid, and it can actually be hard as a clinician when you first start working with someone, because you want to like educate them on that and help them understand that, like, that's probably not the reason why, but they have associated that medication with relief. So like in their mind, it's like, no, that's definitely what's going on for me. So I find it a really tricky medication. And it's really interesting. I don't know. Yeah. I also find it fascinating that, like, obviously they work. And as you said, there's like multiple cases where it just can make sense. But I do find it fascinating that it's a type of medication that has, I don't know, kind of stayed around for so long and is used so readily and long-term. There are definitely doctors out there that have been very specific with their clients and just been like, no, this isn't a long-term thing. But there are absolutely people that have been taking them for years and years on end, which I will be getting into too, part of sort of the further developments down the track as far as digestive health. So I guess to move on from there, I wanted to talk a little bit more about what we see. That sort of opens it up as far as the causes. So we've just chatted about why potentially, this concept of producing too much stomach acid is often not the case. So that for me is like, well, okay, what is it? What else is going on if that's not on the table? So when I have someone presenting with these symptoms, I think, as you said earlier, Christine, like often it is not on its own. There's usually a collection of other factors going on with their gastrointestinal tract. So it's very much about understanding like everything else that's going on that can start to put pieces of the puzzle together as to why they're experiencing their symptoms. I always, first and foremost, are thinking about it as far as like the upper gastric area or the sort of small intestinal tract and up, thinking about like that potentially that upward pressure that could be being created on the stomach as like a physical organ and like how that's being impacted. And I'm also thinking about what's going into the stomach, like day to day, like what is this person eating? What are they drinking? How are they eating and drinking? Like what's that environment like? So there's questions around that. So usually what we'll start to look at is there something going on in the stomach itself, potentially with stomach acid production, but potentially not so much that it's producing too much, but maybe it's not producing enough, and that's causing problems when this person eats, and that's why they're in all of this discomfort, which is really common. To refer back to the podcast that we did a few ago about the stress impacts with people who are eating in a really rushed manner, on the go, stressed out of their minds. They're not getting that nerve innervation and that feedback from the brain being like, okay, it's digest and rest time. Let's make sure we're secreting lots of stomach acid and all of our enzymes are, ready to rumble and help break this food down. So if that in its own right is being impacted, then that's going to be a problem. I've definitely seen that alone be a major cause, which I think for some people just blows their mind because it's kind of like, no, it can't be something as simple as that. But yeah, it actually can be. And then it can be that stomach actually needs some assistance, which I guess we'll get into a little bit as far as like the testing and treatment. But just to hold that in your mind, it can be like, okay, how can we support the stomach in its own right? If it is if it is a little bit inflamed, like what can we do to support the lining? What can we do to help with the actual hydrochloric acid secretion? Then we're thinking about, I mentioned the small intestinal tract. This is Christine's passion area. So it often brings up her questions around SIBO. It's a really common symptom, or reflux is a common symptom with something like SIBO. It's not always the case, but I can tell you, and Christine can tell you, it's super common with all of that increased gas production and fermentation in the small intestinal tract that is just causing a lot of that, as I said earlier, that upward pressure. The other thing, I think, there's so many, and then I'm going to hand over to you, but the other one I wanted to speak to, and this is fresh in my mind with a client recently, is food intolerances. And this can even be linked right back to that eosinophilic esophagitis, where there can be like a strong immune response happening to a food that is causing that immune system sort of eosinophil response. With food intolerances, we can get this inflammation in the esophagus because of these white blood cells and often these eosinophils coming to the area and causing this inflammatory cascade. I, again, see this one quite commonly, and a client recently who changed her diet between her initial to her follow-up with just the food alone, and was diagnosed with GORD as such, and on medication for that. I think she was what was she taking? No, well, it doesn't matter anyway. But essentially, she was very reliant on taking her medication every single day and would use it a little bit more symptomatically. Had not needed her medication at all and felt like the symptoms were not 100% gone, but probably like 10% out of 100. And that was just through the food and removing the food that was causing the inflammatory response. And I think about it as far as the inflammation itself, potentially in the esophagus and stomach region, but it's more than that. When I think about it, it's the logistics of, like, again, the food going through the stomach into the small intestinal tract, and then this inflammatory shitstorm and then how that again creates all of this aggravation, inflammation, upward gastric pressure. So there can be like these multiple avenues as to how this food can cause a problem. So that's probably there's more to add to that, but essentially, the gastric environment itself and what's going on in there, something like SIBO, and then food intolerances. What would you like to add?
I think they're probably the main, I guess, like clinical presentations in terms of, like, if it's not reflux, what is it from a syndrome, a disease, sort of, pathological picture. The only other one that I would probably add to that, which might surprise some people, and it's not necessarily disease pattern by any means, but chronic constipation is another one that I can see quite commonly. And I guess that's for two reasons. The first being that it does, if it's left untreated for a long period of time, you're basically, you've got a lot of stool or, feces that are basically backing up in that large intestinal tract, which then by nature creates sort of a bit of a flow-on effect, but in the wrong direction. So that in itself can lead to something like SIBO, which then, creates a lot more of that upward pressure. But also just on its own as well, in terms of that backlog. You can imagine then, if you're chronically constipated, the food that you're eating then doesn't, the motility is slowed down. And when we're looking at slow motility, it's just this basic backlog effect from there. The other, I guess, side to this, which I do find still quite interesting, is that, yes, we can have a look at, is there like more of an underlying condition or dysbiosis or, some other gut condition going on? But then to the flip side of that, there is actually a lot of just general lifestyle factors that often are at play that I guess I am still somewhat surprised that a lot of people aren't aware of, that they're doing on a day-to-day basis, that can significantly contribute to symptoms of reflux, but also the progression of it getting, significantly worse. So I thought I'd just touch on some of those in case some people just aren't aware of how this can impact reflux. So one of the ones that I see so often, and this is not purely just for reflux, but for general health in general, I don't know if that makes sense, general health, is late night eating. So,
true.
And this is just, it can be a symptom of just daily life. A lot of people, they do work. Potentially they're shift workers as well. So they might have to eat and then, they have to go to bed straight away. But generally this is, it's just not conducive for various reasons in terms of your overall health picture. But what that can do is if you're eating too close to bedtime, when you're going into sort of that, that lying down position, that horizontal position, if your food is still somewhat sitting there and hasn't fully been digested, you are putting extra pressure on that lower esophageal sphincter. So when you're doing that, we all have a late night snack, or we might get home late, from time to time. But if you're somebody that's doing that on a consistent basis, and that might look like having dinner half an hour before bedtime, then that is just continually putting pressure on that sphincter. And over time, that pressure then basically causes that sphincter to lose its tone. And that, if you've got a low esophageal sphincter tone, that's what can then create an issue when we're looking at that. Basically, it's not closing properly, so you can get that backlog of acid into the esophagus. So that's, I guess, one of the main lifestyle factors. But in that same realm, in terms of like what can cause that same lower esophageal sphincter tone, we can be looking at things like diet, for one. So things that would lower the tone by nature, things like your caffeine, and that can come in the form of coffee, energy drinks, some teas as well. Chocolate is another one, which is a bit sad. That can actually lower tone. So yes, these foods can lower tone in and of themselves, but I also like to, I guess, bring a little bit of awareness around, well, when are you having these foods? Are you having, generally people aren't having a coffee before bed, but some people might be having chocolate before bed consecutively. They might be having something like a peppermint or a spearmint tea because they've heard that's good for digestion and good for, it's a caffeine-free option, which is all true. But if that is lowering the tone of the esophagus and then you're going to bed or lying down soon after on a consistent basis, that can be problematic. It may not be enough to, significantly create an entirely new reflux presentation. But if you're somebody that's already doing a number of these different things, that can basically add up over time. The other one is, I've got two more actually. One is similar to the late night eating, is simply eating large meals. So if you're overeating, it's kind of just common sense with this one. You're putting additional pressure on that sphincter. Your body is having to work a lot harder to digest that sort of food, produce a lot more stomach acid, a lot more digestive enzymes, and then you are putting more pressure on the sphincter. And the last one I'll touch on, which I actually find kind of interesting, and I think it's more common than people realize, and that is tight-fitting clothing. And this is generally more of a concern in women. And I see it a lot in young women that are wearing activewear outside of, the gym, or, just it is more of a fashionable trend. I'm certainly guilty of this, staying in your yoga leggings beyond yoga. And, again, it's probably not the thing that's going to be, at the root cause of your reflux, but some of those leggings, some of those tights are pretty darn tight. Mm-hmm. So if you're wearing them consistently, and again, it's more of this like chronic, like, are you doing this? Are you eating late at night? Are you having a lot of these, tone lowering foods? It's like one of those, a bit more of a cluster of symptoms. So there's a few more bits and pieces to that, but I just thought I'd highlight that, yes, there can be more of an underlying gut picture going on, but it can also be more dietary and lifestyle related as well.
Yeah, they're fantastic. I've actually had clients that have come to me and one of their main complaints is the tight clothing in general, like they have a lot going on with their gut, but definitely reflux being part of that, and they just feel like they can't wear anything tight. Like as soon as they put on anything that has any form of sort of sensation, would feel like anything in that area that would have an element of tightness to them would just blow them up, and they just feel so much discomfort. But yeah, it's a really good one to actually suggest, because there are a lot of women walking around in a lot of their sort of tight active wear. And even, I mean, we all feel it. Like if you have left them on and then you finally get out of them, it's like, oh,
Exactly.
everything's just like corseted in.
Exactly. I know. I mean, look, they have their time and place, but yeah, if you're living in them 24/7, maybe something to consider.
Yes. No, they were really valuable. I loved those. So testing and treatment. I feel like this sort of is a little bit, some of them we've mentioned as we've gone through. So testing realistically is going to be more in the realms as if we think something's going on with the gut per se. So do we think that there is something like SIBO going on? We can obviously test for that. Do we think that we need to investigate what's going on with the microbiome as far as potentially a functional stool test? Definitely could be warranted. So they could be two tests straight up that we would look at. There might also be some other types of tests that we could just do through, I'm going to say, I guess, the food or like an elimination style process. So I was speaking to that client case earlier. So part of like a testing process might be, okay, what about if we eliminated a certain food or put you on a certain type of therapeutic food plan? Like, how do you go? How did symptoms change? So that can be used as a tool. Also, we could potentially test if we think certain foods are problematic. So it might be that we're doing a test for gluten intolerance, if we think that needs to be considered, lactose. There are some food sensitivity options out there as far as tests. They're a little bit controversial, but again, I think with the right practitioner and in context of everything else, maybe could be an option. They're probably the main ones I think of, is like how I would use the food as a tool for testing a client. The SIBO, the stool test. Am I missing anything else that you would add as far as testing if I was thinking there's something going on at a deeper level here that I need more information about?
Not necessarily. They probably would be my main my main go-to test. Obviously beyond that, if we're looking outside of our work, you'd be looking at maybe not a colonoscopy, a gastroscopy or an endoscopy, like if you are wanting to get more of a
for sure.
indication, if there's something more pathogenic, I suppose, not pathogenic, pathological about that. So if there is that, deterioration of that tissue. The other one, it's pretty rare that I would do this, and sometimes they might have already had it done, but sometimes you might want to be looking at something like H. pylori as well.
True. Yep.
That can be, generally that goes hand in hand with a lot of other different symptoms, but it's not uncommon. So that would be one that, but often I will see clients that have already done all of that through their GP, and then they're coming to see us and they're like, what next? So
yeah, absolutely. I think the treatment, you've actually outlined some really good things there as far as like, obviously, yes, causes, but in a way, they're a treatment in their own right. Like if you make those changes and they work, then you've treated it through making some changes with your diet and adjusting the clothes that you wear. And also we're speaking earlier to how you're eating as far as a volume of food, but also how stressed are you when you're eating? Are you taking time to eat? So the logics are, as far as treatment, to make sure that we're doing all of those things first. And if that does the job, then great. I think about it as always like a sort of pyramid, as far as like what makes sense first and then moving through it. So the next thing I'm thinking about is like, how can we support the stomach and the esophagus? So what can we do to soothe the environment? So we're looking at things that we can have you take on a daily basis that can help create that nice sort of anti-inflammatory feel. There can be some types of teas. I guess we can speak to some of these things. We're not going to mention product names, but definitely slippery elm is a go-to for me for something like this. I know even myself, like if I'm worked myself up into God knows what state. Actually, I remember when I was shooting the photographs, I had a week off work and I had to get all the photos done for the cookbook, and I was in a whirlwind of stress. I still remember back to that time having really bad heartburn the whole week, and I had the slippery elm out. And I was just like having my slippery elm, and as soon as I would have it, it was just like this soothing blanket. Obviously, the main culprit and cause there was the stress, but highlighting how the slippery elm can help. And a lot of clients will find like a really instant relief with that. So there's certain types of, there's lots of different products actually that will have slippery elm in there, that then they'll have other types of herbs and zinc carnosine and so forth, that like a very, very soothing and healing to the mucosal tissue of the esophagus and the stomach. We might also consider, again, based on the client, but right back to what Christine was saying about PPIs, if it's not an over-acidic environment in the stomach, maybe we actually need to encourage enzyme production. So we can look at having you take enzymes that support the stomach acid. And that can be so amazing. Like just that alone, plus those other things we've just mentioned, can be all that someone needs. So always look at that first, that whole picture. And if that's going to do all the job, great. But then it's going to be more so based from there on the testing if we've gone down that route. So obviously, if we've got SIBO, we're treating SIBO. Obviously, if we have food intolerances, we're working with the diet. And if we've seen this like increased inflammation as a result of like decades of eating inflammatory foods and how that's then affected the microbiome, like we've got some work to do. But our goal is to lower the inflammatory response that's going on, lower that fermentation and that upper gastric pressure. And also, as far as you mentioned too, Christine, like the constipation picture, any sort of like congestion and build up, it's like getting everything moving. So the needle kind of moves, obviously, based on like what the cause is as far as treatment. I think what I love about this area is that we have so many tools in the toolbox, and it feels like an area that is really good as far as results. Like I find that generally getting results as far as like, reflux goes is really exciting for us, because most people have been just diagnosed, this is what you have, and haven't really been given a solution as to like dealing with the why and the underlying cause. We come in and we're like, oh, it's easy. This is what's causing it. We do our investigation, we treat the cause, and like, wow, magic, like problem gone. So I'm not sure again if there's anything you would add to that one.
No, I think you've pretty much covered everything. Like you said, it really does depend on that sort of underlying driver as to what avenues will go down. The only one that I was going to touch on is if there does have, if the main culprit is more of a low stomach acid picture, there is, avenues that we can go down in terms of how to build up that acidity within, or not even the acidity, but the production of that acidity, naturally. And that can look like, well, why aren't you producing enough of that stomach acid? Is there are they key nutrients you're deficient in? So that's when we might want to do like blood testing, making sure you've got enough zinc, you've got enough B12 and things like that to actually produce the stomach acid. Is it actually, like we touched on, more of a stress picture that in those, the way you're eating, the environment that you're eating is actually having an impact on the production of that stomach acid? So that's when we could go in with, looking at managing, the stress and the lifestyles, but how can we in some ways use a bit of a Band-Aid approach to actually support a production of adequate stomach acid while we then address those other factors to get you there naturally.
Yeah, for sure. Is there I'm curious, I obviously mentioned a case of just someone fresh in my mind recently. Is there any clients that come to mind that may not be that you think of that suit this particular scenario that would be a good example for people listening?
Yeah, I've got probably 2 or 3, and they're all really quite different. So the first one that comes to mind is, and again, I don't want to harp on this because I know people sort of roll their eyes, but it's a case where this client came in and she was clearly stressed, like lived a very high-paced lifestyle, had a lot of, I guess, demand on her in terms of the work commitments, largely some at home as well. And so we were working on a lot of different symptoms, but the main one was this reflux, and it was reflux, but it was also very much like a painful, like heartburn type picture as well. And we were doing a lot of work. We were seeing, some significant improvements, but nothing. We hadn't really moved the needle, as far as I would have liked to have seen. She went on a holiday. To like a, like not a travel holiday, like it was purely like just like a tropical destination, ate pretty poorly, drank, like just really sort of let her hair down. Like I'm talking every symptom she had resolved, like not just a mild reduction, like it was like black and white. And then as soon as she came back, everything came back. And, she's like, please do not tell me that this is all being driven by stress. And I just felt terrible. I'm like, look, I mean, I'd love to say that it's something else, but I said like, obviously we don't want you to be, living that lifestyle in terms of your diet and your alcohol intake long term. But I think it's a pretty massive indicator as to how much stress and that sort of nervous system dysregulation was playing a role in that one. And
did she make the changes? Because it's a really hard one.
Yeah, she did, but it was still something she had to manage essentially.
It's really hard. Yeah.
Yeah. So we still went on and we did, as much as we could through the diet, and she, did still need supplemental support on and off as well. So there wasn't, this chronic, magic resolution. She didn't just easily turn her life around, but I think it was quite insightful, but also a bit distressing in some respects as to like, wow, I didn't realize how stressed I was. So yeah, there was that one. And then there was another one that was actually quite, like you said, sometimes we do see that it is quite simple to just completely resolve. But this one was just like almost uncanny in terms of just cutting out caffeine. And it was just like an instant.
Oh, wow.
Yeah, it was just like, but the severity of it that had reduced in terms of like relying on the quickies, chronic cough, up all night, like it was just, sometimes, if you're lucky, it can be just such a simple shift. So I think that just speaks to the fact that, I know some people roll their eyes, are like, oh, does it really matter if I go to bed after eating? And it's like, well, sometimes that's enough to do it.
That's it. No, they're good. They're good examples. I just want to mention one really quickly, but then better wind this up for the day. A client of mine, she's actually a bit more of a long-term client now, a couple of years, but she just came to mind when you were talking. Definitely more of a reflux reason for coming along as her main symptom, but like a lot of mucus. So she's not like coughing it up. It's more like she's like like clearing it all the time. Yeah. So would feel a kind of reflux nature to it, but just could feel this like phlegm more so. She'd always talk about this phlegm. And hers was really interesting in that there was absolutely a food-driven element, like as far as if you think about it, that mucus production, just trying to clear something out, as far as like that immune response. So investigation, definitely there was foods involved. And my thoughts were like, they're the long-term driver of all of this. But because it had been going on, she was like, I don't know, I think she's maybe in her 70s or late 60s. So like a lifetime of this. Like her gut generally just wasn't in the best of state. So we did SIBO testing, and she did have some pretty severe SIBO, which we treated, and that helped a lot with symptoms. But there was always still this food element. But a classic client that, like, we did the work with the SIBO, we did the work around changing her diet. We supported her stomach acid along the way, got her off the medications with time, and just going really, really well. Like, becomes a classic maintenance client, but then was like, oh, maybe I'll have a little bit of this, a little bit of that. Oh, that's sitting fine. I'm not getting that phlegm response anymore. And then lo and behold, I get the email, help.
Yeah.
So what it uncovered is that, yeah, the gut stuff had developed over time because there'd been so much aggravation and inflammation from the food. But once we dealt with that, it became obvious that the main reason is actually the food. So now she knows she's kind of got a line that she really shouldn't push, but she'll still give it a good nudge occasionally. I'll get the email. I won't hear her for 6 months, and she'll be like, help. And we have a bit of a regime we do when it's happened to settle it down, which isn't as complex anymore, which is great. But yeah, it is an interesting case in that it was like a mix of things that definitely were food as the core driver, but how it had, like, over time affected the gut. But yeah, but she knows what to do. It's just sometimes whether she likes to push the boundaries a bit too much. And I guess when you've got a safety blanket in a practitioner, sometimes you do it a bit more.
Certainly guilty of that. How far can I push that boundary today?
That's it. Oh, wonderful. Well, listeners, we hope you enjoyed today's episode. Hopefully that's broken this whole area down nicely for you and you've learned a lot. It's such a common condition. And if you haven't dealt with reflux yourself, I bet you know someone in the family or a friend that does. So we'd love you, as always, to share the episode, helps other people find the podcast. And as always, if you can just take a moment just to hit pause and then go and give us a 5-star rating if you love the show, that means the world. But otherwise, thanks for listening, and we'll catch you next time. Bye.